Hospitals are using technology to explore opportunities for better serving women and their families in hopes of reducing the maternal morbidity and mortality rate in their state. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hedderly, senior writer with AHA. In this Members in Action podcast featuring maternal and child health efforts, we're joined by two leading experts to explore the innovative strategies hospitals are using to engage women and families through technology. Dr. Hyagriv Simhan is a professor in the Department of Obstetrics, Gynecology and Reproductive Science and Division Chief of Maternal Fetal Medicine at UPMC Magee-Womens Hospital in Pittsburgh, Pennsylvania. Also with us today is his colleague Beth Quinn, Program Director of Women's Services for the hospital. Dr. Simhan and Beth, thanks so much for joining us today. Let's jump right in. I'm curious, when and why was UPMC Magee inspired to leverage new technology to support mothers and babies?
I think the rationale for using technology is really as a tool to meet what we perceived as unmet needs. There were and continue to be gaps in care, loss of patient engagement, and insufficient connection between outpatient and home-based care and care within the hospital, certainly for us within obstetrical services. And technology we saw as a tool that was widely used in other industries and other areas of life, but had not been embraced within women's health service or obstetrical care nearly to the level that could have been, and we saw it as an opportunity there. I think given the several years of experience in this arena, we have many use cases of how technology, along with our operational work, have worked well together to reduce gaps in care. Program to engage pregnant women during pregnancy, maximize engagement, education, and self-efficacy for prenatal care, the My Healthy Pregnancy app or digital engagement platform. The second one is our program to monitor blood pressures and symptoms among women who have had a hypertensive disorder of pregnancy to maximize their engagement but also improve clinical outcomes. We have programs utilizing similar technologies to monitor and manage gestational diabetes during pregnancy. And we have used for several years live synchronous video visits via telemedicine to render high-risk pregnancy consultation across a large geography for patients with limited access to the urban academic medical center. And in relatively recent history, we have begun piloting prenatal visits using live synchronous video visits in the patient's home for a similar reason. Those are some examples of programs that have been in place here, in some cases for years and in others just for months.
Can you share some of the outcomes, specifically on engaging mothers and families? What's been the impact on the patient experience?
Yeah, I think that's the one that we have the most data collected on and have been doing that the longest. We started that program back in February of 2018 and have continued to grow that at Magee, but because Magee is part of a larger system, we are also starting to spread to some of our other hospitals. We have enrolled in that program well over 1,500 patients in the last 2 years. And in doing so, we provide some standardized education and give the patients a blood pressure cuff, allow them to use their own smartphone device to receive texts and then to send text messages back and responses to symptomatic questions. We also have a call center of nurses that are watching that and are able to respond to that. So they're able to do some treatment algorithms that we have developed and to use some of our providers to make initiation of medications, things like that, to avoid patients needing to come into the office or come back into the emergency department. So out of the 1,500 patients plus that we have enrolled so far, the things we're really key on monitoring and that we feel really positive about, I think, are the fact that about 43% of those patients did not need to come in for a 1-week blood pressure check, which is kind of a roadmap of what most of the providers will do. Is if a patient historically goes home with a hypertensive diagnosis on medications or not, they would tell them to follow up in 1 week just for a blood pressure check in the office. And we have not needed that, and about 43% of the patients have been able to stay home. But I think when we looked recently at the other data, the comparator of that, about 90% of the patients we've enrolled have sent us blood pressures in the first week, so we really have a very high engagement of patients sending us blood pressures. And they send us up to 5 times a week. We get those blood pressures in. And so the follow-up visit for us in that 4 to 6 weeks historical postpartum follow-up visit, we have well over 80%, usually closer to 90% of engagement with follow-up visit, which is much higher than a national average. And I think initiation of medications with our patients or some kind of manipulation of medications, I guess we could say, because sometimes they go home on one, we up the dose, or we give them a second medication, or we decrease based on what their blood pressure ranges are over the 6 weeks that we keep them engaged in the program. We are well over 40% management of that, closer to 50% of our patients that we are managing medication changes on as well during that period. One of the other things is the PCP follow-up as well. When we first looked at our first population in the first year of this population of patients to see, are they following up with a primary care physician beyond the episode of pregnancy, beyond the obstetrician visit? We had approximately 80 women do that. At some point in the first year, they had some kind of contact with a provider outside of an OB-GYN. And then in this second year of 2019, we doubled. We were well over 250 women that had done that. So we are increasing because of the knowledge and education we're providing.
I was going to reflect on our experience with live synchronous video visits for high-risk pregnancy care, for maternal fetal medicine care, and the impact we've seen in the region. You know, one of the big contributors to the increase in morbidity and mortality we've seen in the U.S. is an increase in the frequency and severity of underlying medical conditions that women come into pregnancy with, things like diabetes and chronic hypertension, autoimmune disease, et cetera. And one of the important resources, maternal fetal medicine consultation and disease management, can help improve those things, but access to those services has been a barrier to their wider spread adoption. There are, on average, something like one maternal fetal medicine provider for about every 4,000 births in the U.S., which is a relatively low availability, and there's fair geographic disparity in access to that care with the concentration in urban and coastal regions. So rural communities or suburban communities, less population-dense communities have even less access to maternal fetal medicine care. This is true in western Pennsylvania as well. At this juncture, we do something like approximately 2,000 live synchronous video MFM consults across a big geography per year. Our experience has been, from a patient perspective, patients on average save approximately $100 per visit just in travel and associated costs sort of directly in their pockets. That's financial savings for patients themselves. The patient experience with telemedicine services have been outstanding. They actually far outstrip the performance of our face-to-face services in general because patients aren't taking as much time out of their day. They can bring their families to their visits. They stay in their community. They're not fighting parking and the like. And we've demonstrated an improvement in birth outcomes when these services become available to the community. With respect to diabetes management, we've demonstrated improved glucose control, reduced cesarean rate, reduced large for gestational age status in babies when we can manage diabetes across distance enabled by technology. So that's another example of patient experience and clinical outcomes that we've been able to improve, not necessarily because of technology, but certainly enabled by technology, that live synchronous video visit.
Can you describe some of the challenges and unexpected improvements from this initiative?
Patient experience things are really good, positive things. We get patient stories of women that are saying that this has been great for them because they feel like they can stay home and still be monitored and still feel connected to the care that they would have received if they were here. Even we've had nurses and providers that have delivered and been part of our program that have felt just knowing, even though they know what it is to have a high range blood pressure or what they should be looking for, having someone else to bounce that off of and someone to remind them to take it, that's been very positive for us as well.
Two things I'll talk about with respect to barriers broadly is, one is our regulatory in terms of the regulation of the rendering of medical service, and then regulatory with respect to reimbursement. These are strategies for rendering clinical care and keeping populations healthier and safer, that are innovative and are novel, and there is fair lag. Now that these have been in place for almost a decade, really the regulatory environment and reimbursement environment ought to essentially catch up to allow these programs to be scalable. We've been fortunate to be in a system that has been forward-thinking and has not just permitted but fostered the development of these programs, and we've thus been able to grow them as we have. But scaling them within our own system or adoption in other systems, I think those regulatory and reimbursement challenges need to be faced. And then the second thing I'd add is connectivity. If we're relying on cell coverage or Wi-Fi coverage for patients to use devices in their home or communicate with us, that those might vary from region to region and particularly in rural areas. And so that's a challenge as well. We've been able to circumvent that through a variety of technological solutions, but we've had to deal with workarounds because of the relatively underdeveloped infrastructure in some of these places.
So what's next for UPMC Magee? How do you see current initiatives growing and evolving? And do you have any new initiatives on the horizon that you can talk about now?
I think a culture that embraces the desire to be better. Systems are, in general, designed perfectly well to achieve the results that they do achieve, right? And so in order to move the needle, we can't just keep doing the same thing over and over again. I think that as a concept is fine and generally accepted, but to really embrace that as an organization, I think is unique, and we've been lucky to be able to work in that kind of environment. I do think one of the things that even forward-thinking organizations have to be intentional about is avoiding the problem of what I call pilotitis, which is there's lots of enthusiasm up front for piloting programs, and in fact, early returns might be high, but scaling across a distribution of geography, an increased number of patients, for programs to be self-sustaining is really important. And so to go from concept to program that's in a pilot phase to then scale is a really important part of the life cycle of innovation, I think, in this space, and needs active attention. Second part of your question was, what are some of the things, where are we looking to? We embrace the concept of remote monitoring and that there are conditions in a population for which you might be able to do surveillance and preventive strategies and address things to improve clinical outcomes and reduce cost beyond hypertension, which is the one we've mentioned now. We have interest in connecting some of our programs, so connecting our pregnancy app or digital engagement platform to a remote monitoring program in clinical use cases like depression or mood disorder, to be able to identify risk and then provide services to patients close to where they live, including in their home. We're excited about that concept and perinatal mood disorder as a first use case of that.
Yeah, I think that as we talk about the app and several of our other initiatives, it is very much technology-based, and we are trying to do a lot around that because we realize that's where most of our patients will benefit from being at home. We have, especially in an OB population, it's a young population, so we know that most of them have phones and want to communicate in that way, so we are working with that. I think what we have realized, and Hy and I have talked about this before, is we look at all of our programs, we realize a lot of times it does come back to the human factor as well, though, and so not just the patient, but having more standardization and centralization of programs and working with centralized processes of monitoring for all of our programs, for the remote monitoring, for the pregnancy app, for any of our depression screenings that we do across the system. As we look at all of those things, I think we're trying to figure out how best that we can use technology but still have a human factor that's doing the monitoring and the outreach as well.
And to be able to integrate technology into essentially an existing operational infrastructure is important. And I think it is really appealing to be enamored by the shiny new object, the ability of technology to do something. But just because you can do something doesn't mean that you should, and the way in which it's integrated is relevant. An example I'll give is maybe the way that hasn't worked well is things that the electronic medical record has done in terms of contributing to provider-side burden and actually difficulties in communicating among providers or with patients, and there's a long history therein. So when we are thinking of, for example, using machine learning and artificial intelligence to help augment clinical decision-making, around blood pressure management, we have the capability of using data to produce those decision support tools. But being able to deliver it to providers in a way that's useful to them and not burdensome is as important as the technology itself. It's really critical to understand the human component of this too, like Beth said.
It's very impressive how innovative UPMC Magee-Womens Hospital has been in improving the health of mothers and babies through initiatives such as Vivify, My Healthy Pregnancy app, and other technology. Thank you, Dr. Simhan and Beth, for joining us today and sharing more information about this important program.
Thanks for having us.
This has been an excellent example of how engaging mothers and their families improves outcomes for mothers and babies. For more podcasts and additional tools, resources, and education to improve outcomes for mothers and babies, please visit the Maternal and Child Health website at www.aha.org/advocacy/maternal and child health. And thanks for listening.